Hepatotoxicity, a comprehensive review. Hepatotoxicity refers to liver damage caused by exposure to toxic substances, including drug, chemical, herbal products, and infections. So, drug-induced liver injury, that is DILI, DILI, is a major cause of hepatotoxicity, with anti-tuberculous TB drugs being a common cause, particularly isoniazid, rifampicin, and pyrazinamide, causes an etiology of hepatotoxicity. It can result from multiple factors, including drug-induced hepatotoxicity, that is DILI, anti-TB drugs, isoniazid, rifampicin, pyrazinamide, and ethonamide. Antibiotics like amoxicillin, cavelinate, nitrofurantoin, non-steroidal anti-inflammatory drugs, NSAID, diclofenac, paracetamol overdose, anti-epileptic like valproate and phenytoin, herbal and dietary supplement like green tea extract, kava, chemotherapy agents, methotrexate, cyclophosphamide, viral hepatitis and infections. Hepatitis A, B, C, D, E, cytomegalovirus, that is CMV, Epstein-Barr virus, EBV, autoimmune and genetic causes, autoimmune hepatitis, Wilson's disease, hemochromatosis, alcohol and metabolic disorders, alcoholic liver disease, non-alcoholic fatty liver disease, that is NAFLD, obesity and insulin resistance. So, what are the clinical manifestations? Hepatotoxicity may present with a wide range of symptoms from mild to severe liver failure. So, in mild case, there is a fatigue or tiredness, malaise like a feverish feeling, nausea, vomiting. In a moderate cases, jaundice, dark urine, pale stool, pruritus, and in severe cases, hepatic encephalopathy, ascites, coagulopathy. Specific to anti-TB drug, isoniazid is a hepatocellular injury in which elevated ALT and AST, HGOT, HGPT, rifampicin, cholestatic injury, that is increased bilirubin, ALP, pyrazinamide, severe hepatotoxicity with necrosis. Diagnostic assessment. First is a laboratory test, liver function test, LFT shows HGOT, HGPT, alkaline phosphate, GGT, bilirubin, coagulation profile, prothrombin time and INR for liver failure assessment, serological test, hepatitis A, B, C screening, autoimmune markers, ANA, ASMA, IgE levels, metabolic workup, serum, ceruloplasmin for Wilson disease, iron studies, imaging studies, ultrasound abdomen, liver texture, steatosis, fibrosis, MRI and MRCP, biliary obstruction, cholestasis, transient elastography, that is fibroscan, liver stiffness measurement, liver biopsy if diagnosis unclear, confirm hepatocellular, hepatocellular versus cholestatic injury, identify fibrosis and cirrhosis, treatment and management. General management, immediate drug discontinuation, that is a stop suspected hepatotoxic agent, supportive care, IV fluids, symptomatic treatment, avoid alcohol and hepatotoxic drugs, specific therapies, N-acetylcysteine, that is NSA, for acetoaminophene toxicity, corticosteroid for autoimmune hepatitis, vitamin E and ursodeoxycholic acid UDCA for NAFLD, non-alcoholic fatty liver disease and cholestatic liver injury. Liver transplant for permanent hepatic failure with encephalopathy and coagulopathy. Hepatotoxicity due to anti-TB drugs. Risk factor are age more than 35 years, pre-existing liver disease like hepatitis B or C, and alcoholism, malnutrition, HIV co-infection, management of anti-TB drug-induced hepatotoxicity. Mild cases, SGOT, SGPT less than 3 to 5 times upper limit of normal, monitor LFT, continue treatment. Moderate to severe cases, more than 5 times upper limit of normal or symptomatic, stop TB drug, switch to liver friendly regime, modified regime, non-hepatotoxic regime like streptomycin, ethambutol plus fluoroquinolone, that is levofloxacin. Mostly avoid ciprofloxacin. Sequential introduction after normalization of LFT. Preventive strategy, baseline LFT initiating anti-TB therapy, regular monitoring, weekly LFT in high-risk patients, use of hepatoprotective agent, silymarin, N-acetylcysteine, avoiding alcohol and unnecessary polypharmacy, patients' education on symptoms of hepatotoxicity, future perspective in hepatotoxicity, management, personalized medicine, genetic screening for susceptibility, novel biomarkers, mRNA, cytokines for early detection, hepatoprotective agents, ongoing research on herbal and synthetic hepatoprotectants, safer anti-TB regimes, development of new drug with lesser hepatotoxicity. Thank you.